Thank you for joining us, Professor Murthy, for this session on the epidemiology of diabetic retinopathy. As we know, there is a global epidemic of diabetes with over 314 million people who are affected by diabetes. In order to understand the ophthalmic complication of diabetic retinopathy, we do know there is an international classification. How useful is this as a case definition for epidemiological studies?
The most important thing that we have to keep in mind is that 90% of the vision loss that occurs in diabetes can be prevented by excellent, adequate, appropriate management of diabetes. And therefore, classification systems have a great role to play in helping us understand who needs what treatment so that the vision loss can be prevented. There have been efforts in 1968 to try and develop classification systems, and now we have an international classification system which is used widely across the globe, which actually looks at 5 grades of retinopathy, starting from no retinopathy, and then going through stages of mild, moderate, proliferative diabetic retinopathy, which actually indicate the severity of the disease. The big importance of this is, given the lack of ophthalmologists across the globe, it is exceedingly difficult to have people with diabetes being examined only by the ophthalmologists. So having an opportunity of classifying and a categorization system which is universally acceptable allows non-ophthalmologists to actually play a role in the initial screening of the disease status, and therefore it reduces the workload on the ophthalmologist and increases the efficiency of the system which manages individuals with diabetic retinopathy. The other important thing is prognosis. So there is a natural progression across each of these stages from no retinopathy to proliferative diabetic retinopathy, and therefore it helps us to look at whether treatment is working and what treatment needs to be instituted at what stage. So therefore, the international classification systems have a great role to play in managing patients effectively and in reducing the workload on an already overloaded eye care system.
The WHO has said that more than 80% of the diabetes is in low and middle income countries. What do we know about the magnitude of diabetic retinopathy?
Right. Now that's something which is very critical, because there is this opinion that people share that diabetic retinopathy is not a problem in many of the low and middle income countries. The reality is different. At the moment, whatever evidence we have shows that diabetic retinopathy is the commonest cause of blindness amongst the productive age groups in most of the high-income countries. When it comes to low-income and middle-income countries, we find that the prevalence of diabetes was very low till about 2 decades ago. But with the changing lifestyles and life patterns, increasing sedentary lifestyles, no exercise, there is an increasing trend in the prevalence of diabetes in most of the low and middle income countries. We now know that 2 countries, India and China together, have about 170 million people living with diabetes, which is exactly 50% of the global magnitude of diabetes. Now, till now, they have not had a major epidemic or a high prevalence of diabetic retinopathy, because the prevalence of diabetes has been very recent. The increasing prevalence has been very recent. Epidemiological evidence shows that it takes about 15 to 20 years of the diabetic state to develop changes in the retina. So people have to live long enough to actually manifest the changes that one sees in the retina. Most of these countries like India and China, there is a sudden increase, a dramatic increase in life expectancies, and people with diabetes are now living longer. The minute they live longer, the prevalence of diabetic retinopathy is bound to increase. There's been a recent review of about 35 population-based studies across the globe looking at the prevalence of diabetic retinopathy. We see that the prevalence in the high-income countries of diabetic retinopathy amongst persons with diabetes is about 30 to 50%. When you look at the low middle income countries currently, it is between 10 to 30%, 10 to 25% in more instances. So the prevalence at the moment is low, but with increasing life expectancies, the prevalence of diabetic retinopathy and the magnitude or the number of people suffering from diabetic retinopathy in the low and middle income countries is also bound to increase. So we are actually at the tip of the starting curve of the epidemic of diabetic retinopathy. In the next 2 decades, we'll see significant changes in the prevalence in the low and middle income countries also.
Amongst the various study designs that have taken place to understand a bit more about diabetic retinopathy, could you highlight how cohort studies have been used to understand the determinants of diabetic retinopathy, and what do we already know about determinants of diabetic retinopathy?
Right, that's again a very interesting question. The reason why cohort studies are so critical for diabetes is that diabetes is a long-standing chronic disease. Changes in risk factors over a period of a number of years is critical for changes to occur in the manifestations of either diabetes or of diabetic retinopathy. The risk factor may be actually acting right through the life course, so 10 years, 15 years, or there may be a sudden spike in a risk factor. The sudden spike is not as critical as the long exposure to the risk factor, and therefore to capture events right across the life course, as type 2 diabetes, you're looking at all the adult life age groups, and in type 1 diabetes, it's a life course analysis that you need to look at to try and look at what time of life does a particular risk factor have more influence on the risk of developing vision loss in diabetes. And therefore, unless you look at all these factors, working over a long period of time, collecting data regularly at periodic intervals, we will not be in a position to understand the natural progression of a disease like diabetic retinopathy. This is contrary to what we see in many of the acute conditions where the risk factor occurs suddenly and you see the manifestation immediately. But in a condition like diabetes, you need to actually look across the lifespan, and therefore cohort disease epidemiology is so critical in understanding diabetic retinopathy. At the outset, we need to actually look at the risk factors for diabetes as being different from the risk factors or determinants for diabetic retinopathy. They may not be the same. In fact, some of the risk factors for diabetes, for example, do not influence the cause of the disease like diabetic retinopathy. Some of the important determinants, the duration of diabetes, how long the individual has been having the diabetic state, how good has been the control of diabetes, what we call as a glycemic state. Has the individual been able to control his diabetes, his or her diabetes effectively? That is another important determinant. The presence of comorbidities like hypertension, like renal disease, elevated lipids, and conditions like increasing age, gender, access to health care, especially in rural populations where getting medication or coming to the attention of an eye care provider may be compromised, are important determinants. Amongst all these, the most important perhaps are the duration of the diabetic state as well as how effectively has the diabetes been controlled.
Based on what we already understand about diabetic retinopathy, what are the priorities and challenges for action to address this diabetic retinopathy need across all populations?
The main challenge is a big challenge for looking at diabetic retinopathy. The most important thing that we need to look at is how do we prevent the loss of vision in diabetes. So programs which look at screening out individuals who are at higher risk of developing vision loss are the more important programs to look at. And these are what we generally call as screening programs, where we try and look at the retina of eyes or retina of people with diabetes, so that those individuals who have advanced stages of retinopathy are immediately brought in for treatment. Now, this screening program has been used effectively in a number of places across the world and has been found to be effective not only in the high-income countries but also in the low and middle-income countries. We have screening programs in India, in China, in addition to the high-income countries like the United Kingdom. That is one of the most important priorities, to institute screening programs which can effectively pick up individuals who are at high risk of losing vision because of diabetes. There is a scarcity of ophthalmologists across the globe, and if ophthalmologists were to only look at diabetic retinopathy, it would mean that all the other eye diseases would suffer. So we need a system of task shifting, and what we could do in a screening program is to use imaging techniques which can then give the responsibility of screening out those who are at a risk of vision loss early enough by using digital imaging technology and using personnel like optometrists, ophthalmic assistants, and ophthalmic nurses, and that has been seen to be a very effective strategy going forward. The most important thing that we have to remember is that diabetes and its management is not for the ophthalmologist. It is a physician or a diabetologist who's actually managing the diabetes and its complications in individuals. So unless we have a comprehensive program where the physicians are equally involved with the management of diabetic retinopathy, we may not be able to achieve much. Just treating somebody with a laser is not going to be adequate to control the diabetic state, and therefore involving physicians is again a critical step as the way going forward. The other important thing that we just learned from a big study in India, where we had 11 cities being surveyed, what we found, which was actually astonishing to most of us, was that 50% of the diabetics, or persons with diabetes, the first time they came to an eye care practitioner, they were already blind or visually impaired. It therefore means that people come to an ophthalmologist very late in the disease. We need then to be proactive and go out into the community, go into the physician clinics and try and screen for diabetic retinopathy at a very early stage before the eye has been damaged beyond repair. So that is a paradigm shift. Innovation in terms of involving physicians and other community representatives who treat diabetes rather than depend on the persons with diabetes actually come to an eye clinic which is normally very late in disease. The other important thing is that a large number of people with diabetes do not actually seek treatment or do not comply with treatment, and therefore any of the strategies that we look at has to have a strong educational and counseling component which looks at not only the persons with diabetes but also families where individuals have diabetes, so that effective action can be instituted. So a number of ways in which we need to move forward and not just depend on the individual actually walking into an eye clinic very late in the disease.
So what would you say are the key research questions that we need to urgently address in diabetic retinopathy?
In terms of the research priorities in diabetic retinopathy, I could actually categorize them into two boxes. The first is in terms of the clinical management of diabetes and diabetic retinopathy, and the second is the operational and epidemiological research priorities so that the access to services can improve. If I look at the first box, which is the clinical management, the priorities there are to try and bring in technology which can enable us to identify the retinal changes without having to dilate the pupil. So non-mydriatic digital imaging systems will go a long way in actually improving screening, increasing the reach of technology, and allowing people to agree to being screened for the eye complications. So that is one of the important things that we need to look at. The second important thing in terms of the clinical management is that the current technology of treatment is not very good. It's not very interesting for many people, in the sense that either laser or surgery like vitrectomy is more destructive rather than constructive. And therefore we need to look at treatment procedures which are easier to deliver and which are better in terms of long-term prognosis. We have made a movement in that direction with the use of the intravitreal injections, the use of anti-VEGFs, and that is still under a lot of trial. A lot of individuals looking at them as something which can potentially change the face of management of diabetic retinopathy. That needs to be persevered with in terms of a research priority on the clinical side. On the operations side, how do we get individuals to be examined early in the disease process without having to actually visit an eye clinic? If you're able to manage the use of Android platforms, smartphones, and if you could use their potential to improve the imaging techniques, like we have something called the PEAK, we have other digital imaging technologies. In fact, there are at least 10 different companies across the globe which are toying with different digital imaging techniques for diabetic retinopathy. And that actually would help in task shifting, because a smartphone can be used by anybody who has minimal skills. You don't need an ophthalmologist to do that, but that makes a big difference in early detection. So looking at such technology which can be available right across is very important. Perhaps this also helps in reducing the costs of treatment. Currently, anti-VEGFs are very expensive, and therefore to look at alternatives which reduce the costs, increase the effectiveness, and increase the reach of services is perhaps a research priority in terms of managing a program for diabetic retinopathy. So both operational as well as clinical research priorities need to be emphasized at the moment.